Today's sessions will be based on the form of academic presentations where our esteemed audience is invited to engage with the speakers at the end of each session. Our first presentation is titled Clot and Clock, the Dual Threat of Acute Coronary Syndrome. This academic session will be delivered by none other than Dr. Gotabe Ranasinghe, who is a well-known senior cardiologist and a general and interventional cardiologist.
Thank you for kind words, and also I must thank Ceylon College of Physicians President Namal Vijayasinghe, Secretary my friend Dinuka Liyanage, and President College of Cardiology Asanka Dunwila, and Tusita Amarasinghe. So I think I feel privileged to be here and talk about acute coronary syndrome. And so this is a very common topic. I try my best to complete everything. But it's actually a race between clot and clock. There are two enemies here, the racing. And clot is acute occlusion of the coronary artery. Clock is how much myocardium we salvage. We should defeat the clock and let the clot win, and so early reperfusion. So that's the aim. And so this is the outline of my lecture. So introduction to acute coronary syndrome, then triage and diagnosis, then acute management and revascularization, then pharmacological treatment, complication, and conclusion. So the acute coronary syndrome, I think, encompasses several clinical syndrome, usually unstable angina, and non-STEMI and STEMI. And so these are the main groups, three main clinical diagnoses of acute coronary syndrome, and we encounter every day. And so let's talk bit about our local scenario, because local scenario we don't see very much in the scene. So number of AMI patients in Sri Lanka. So usually, according to Sri Lanka STEMI Forum statistics as well as Ministry of Health, we have about 63,000 per year, 5,000 per month, and 175 to 200 a day. So see that staggering numbers. And so this one has to understand. Acute MI, of course, they say they don't categorize STEMI and non-STEMI, but all together here. And see the number of AMI encountered Sri Lanka over the years. And from 2017 to 2023 here, 22 rather. And so see again, over the years, there is an exponential rise. And so we are facing a sort of epidemic of this problem. And also, we talk about various things about this acute coronary syndrome, how the atherosclerosis begins, various theories. This is what I believe, this is the whole world now believe, inflammation. And so inflammation is the key, nothing else. And so how does inflammation start? Acute oxidative stress, oxidized LDL, endothelial dysfunction, LDL accumulation in the intima, inflammatory reaction, plaque buildup, and rupture. So this is what exactly is happening with acute coronary syndrome. So the inflammation is the center, and this is the central problem for anything, everything. Not diabetes, not hypertension. Those are all risk factors, but we always traditionally talk about these things. But someone has to see what's going on there. It's an inflammation. What is this oxidative stress? All sugar, other various oxidative stress factors, lack of sleep, all that come into play. And especially the seed oils, what we take, all matters. And so this is the trial I just want to highlight. It's called Cantor study, and that you can see that's proven that there is an inflammatory process happening in the endothelium. And so this is not LDL per se, it has to be oxidized LDL. So this study, of course, proved that there is inflammation happening in the artery wall. Also rare causes of other than the inflammation, so it's CADSIL syndrome, there's another syndrome called Kunis. and Kunis syndrome. So the SCADL, of course, I reported first time in the world, and so this is, of course, a autosomal dominant condition, and there is no atherosclerosis here, and so this is published recently and going as a new syndrome. You get a spontaneous coronary dissection of the coronary artery, they come with acute STEMI, and so then the Scadacil, of course, described some time ago, again autosomal dominant condition, and again they have more or less TIAs and neurological symptoms, but they can come later on with the STEMI. Usually young age they present. So I'm just mentioning these things. One has to understand, because we see these things in the day-to-day practice. And so CADL and CADASIL, of course, there are two variants. So mutations are different, chromosomes are different, and so therefore it's two syndromes. And so one has to remember. And Kunis syndrome, this is described in 1991, Greek cardiologist. And so there's the allergen exposure triggers mast cell degranulation and the release of various vasoactive agents and causing atherosclerotic plaque rupture or erosion, even spasm. And you can see the various types, the coronary spasm. Of course, you see this after the bee stings and wasp stings and hornet stings. It's very common. So they say allergic reaction, because of allergic reaction they died. But if you see, sometimes it's a heart attack. And type 1, type 2, type 3. So type 1 usually vasospasm. Type 2 is people who have already plaque, they can rupture because of this situation. And people who have got stents and also can have stent thrombosis as well as stent restenosis because of this allergic reaction. Then the triage and the diagnosis is very important in case of acute coronary syndrome, because the clot and the clot, as I mentioned, and so you have to make sure that you have to understand that the thrombotic burden and the ischemic time matters a lot and for the clinical outcome. And so therefore the clot is very important, because early reperfusion is the most important thing to prevent myocardial damage. And so therefore initial measures for patient with present with acute coronary syndrome has to have some system: pre-hospital logistic care, time to treatment, healthcare system and system delays, emergency medical services, and even general practitioners, what they do, so their diagnosis, and organization of STEMI treatment network. That's also important to minimize delay. So I'll talk about each and every one, one by one. And so we introduced this wagon wheel model of STEMI care in Sri Lanka 2011, and by Sri Lanka STEMI Forum and as well as Sri Lanka Heart Association, endorsed by Ceylon College of Physicians at that time. And it's a protocol specifying the reperfusion strategy based on geographical location of patient's first medical contact and the regional availability of the cath lab services to achieve better adherence to guideline recommendation. So we introduced this wagon wheel model, and you can see. And so the hub is actually the center, the cath lab. We can do this in our country because there are 9 provinces. All the provinces have got now cath labs. And so therefore, depend on the level. So level 1 is the hub. And all the hospital we have mapped and the primary PCI. Level 2 is outside that. And the transfer for primary PCI, and other level 3 is a pharmacoinvasive, which I'm going to talk to you later on. And so this is the Western province we have already mapped. Depending on the hospitals, we can see now, for example, Gampaha, level 3. And so it comes, you give thrombolytic therapy, transfer, pharmacoinvasive. So depending on the geographical location, we can map all 7 provinces. So that's very important. And also the quality evaluation, we have to have some idea about what's going on in Sri Lanka. These are the data. This is published in the British Medical Journal. And quality evaluation we have done in Sri Lanka, and highlight the need for improved referral pathway and stronger PCI center network. So this study concluded that AMI care quality showed moderate overall compliance with major gaps in organizational system, highlighting the need for better referral pathways and networking with PCI centers in Sri Lanka. At the moment, we have gaps, so there are so we have to address this. This study beautifully showed the gaps. And also another one we published, the door to balloon time. Now see, the average is more than, this is in Western province, and this again published in BMJ, and door to balloon time more than 120 minutes, and that reflects in mortality. So even this study, door to balloon time delays more than 120 minutes were associated with increase in hospital mortality with old age and female patients identified as independent predictors, highlighting the need for faster patient transfer, early decision making. There are delays in decision making sometimes at various levels. And this is, by the way, Central Province, including National Hospital, Colombo. And so diagnosis tools for suspected ACS. Of course, you see the very, very important ECGs. We have to take ECG within 10 minutes, and so that's guideline very clearly mentioned here, and prevent the delay. And so ECG changes, and 12-lead ECG is the most important diagnostic tool. So if it is a stable angina, of course you see normal. Unstable angina, again you see normal. Non-STEMI, you can see T inversion, and so maybe symmetrical or asymmetrical. And STEMI, you can see beautiful ST elevation, so one should not miss that. And there are other things like AVR ST elevation. So always look at the AVR, especially when the symptoms are very suggestive of STEMI, because you tend to miss this AVR. And so when in case of AVR, you see beautiful, not for the patient, but for us, is ST elevation. And the other lead, you can see ST depressions. And so, and also the new left bundle branch block and the right bundle branch block with ischemic symptom. Always we have to suspect acute coronary syndrome. That, of course, we have to look and ask for all ECG. That's people don't, I don't see that very many people do that. And other ECG changes, as I told you, see the STEMI, J-point elevation. You have to differentiate from other conditions like pericarditis and all that. And then hyperacute T waves, also very suggestive of STEMI. Early stages, you can see very broad, tall T. And then D-winter T is again where the peak T, before that there's a ST depression. You can see it here. And so that also very, very suggestive, early stage of STEMI. And the posterior STEMI, so you can see posterior MI is suggested by the presence of ST depression in V2 to V3 and tall wave. And so you can see other leads like V7 to V8, V9 if you have to take in that case, and see the ST depressions and so ST elevations, so those leads. And so cerebral T waves, of course, we all know that there are cerebral conditions. So sometimes we have T inversion. That, of course, may not be an infarct. And see, this is another classic ECG features of proximal LCA occlusion. You can see ST depressions and ST elevations. So it's various leads. So one has to understand these the changes sometimes people miss. And so this is a kind of posterior MI. And where you see peak T in anterior chest lead and ST elevation in opposite leads. And biomarkers, of course, high sensitivity cardiac troponin is recommended in all patients with suspected STEMI. If the clinical presentation is compatible with MI, then the rise and fall of all you can monitor. And so you have to take it above the 99th percentile. And so diagnosis is very important there with the clinical symptoms. You can see the pattern, the rising early hours, and then after 6-7 days the levels goes down. So that's, of course, yes, but you should never wait for this test to diagnose STEMI. And so in ACC-HA2 latest guidelines, it's highlight the fact that troponin should be measured as soon as possible, preferably using high sensitivity assays. And that is a very, very important test. And also, and in patients suspected of ACS with initial high sensitivity troponin, non-diagnostic, then recommend time intervals, the 1 to 2 hours later, or maybe even 3 to 6 hours later. This is the, again, latest guidelines. Then the acute management and revascularization. So emergency care, of course, initial diagnosis and monitoring once done. So acute pharmacotherapy, very important for all these acute patients. And usually we give oxygen, nitrates, pain relief, and some centers give beta blockers and aspirin. OP2 I12 inhibitor, depending on the situation and the condition, we always do that. And also the oxygen, now see if the oxygen saturation is less than 90, of course then you have to give the oxygen, otherwise you should not. The guidelines strongly recommend that. And if the saturation is more than 90, and you should not do that. Now when we were house officers, of course we used to do each and every patient. Now you don't do, because that might cause harm. And so time, myocardial infarct size and outcome. This is the most important thing, the time to treatment and myocardial infarct size and mortality. This is a beautiful study done by Gersh and others, published in JAMA. And then time, symptom onset to reperfusion therapy. And this method, and in this study, you can see every 30 minutes delay associated with 7.5% relative risk of 1 year mortality. That's very, very significant. That this study concluded early reperfusion dramatically reduces the infarct size. Early treatment produces the greatest mortality reduction. According to this, you can see first 3 hours, significant reduction. And even late reperfusion may improve the survival. Even the myocardial salvage is small. You can see after 6 hours, the salvage is small, but still you can minimize arrhythmias, you can minimize the scar formation, you can minimize the remodeling. That is another thing happening if you even reperfuse up to even 12 hours. The selection of invasive strategy for reperfusion therapy. So this is gray score. According to that, you can select. And so these patients, very high risk patients. So, and when the patient comes, suppose it's suspected non-STEMI, and very high risk patients, of course, immediately within 2 hours, you have to send for angiogram. And so how then you can see the very high risk features and changing dynamic ECG changes, hemodynamic instability, arrhythmias, and various things. High risk patients, again, so you can see here, depending on gray score, that you can see the gray score, 8 clinical variables, and these variables together estimate the mortal risk in acute coronary syndrome. And if the gray score is more than 140, that identify the high-risk, the non-STEMI patients who benefit from early the invasive therapy. They should be transferred to PCI center for revascularization. Then the low-risk patients, of course, if they don't have these features, they are low risk, and you can do inpatients transfer. So you can transfer to another hospital and evaluate further and do a exercise ECG, echo, and repeat troponin, assess further, and depending on that, you decide on the revascularization. So that's for non-STEMI. The STEMI, of course, the onset of symptoms you can see depending on the mode of transport patient. Sometimes they come from on their own, sometimes patients come through their emergency services. And so most importantly, first the medical contact. And so then from there you decide on what type of reperfusion therapy. And so if they come within the less than expected time, that is the 2 hours. Now suppose when the patient comes to you, and if the ideal treatment should be the primary PCI. If you think that primary PCI can be done after 2 hours, then you should not wait and send patient for thrombolysis. All other patients, if they are coming, if you think that expected PCI can be done within 2 hours, you should send the patient for primary PCI. There is no question about it. That's very, very important. And so then with the type of reperfusion strategies, fibrinolysis or thrombolysis, and this therapy is important reperfusion strategy for STEMI patient. In this country still, I think more than 80% of patients get this. And so presenting within 12 hours of symptoms, and so there are the primary PCI facilities not available. And successful reperfusion is generally associated with significant improvement of ischemic symptoms and ST resolution more than 50% and very good hemodynamic status. And we know basic about this, what is happening here. Thrombin is actually activated, thrombosis, and then ultimately we give plasminogen activity to dissolve the thrombus, the fundamentals. And the clinical benefit of thrombolytic therapy are very well established. And so the significantly reduced short-term mortality in AMI, particularly in patients with STEMI or bundle branch block. And this study very clearly shows that early hours, the benefit is very much more. And the different thrombolytic agents, first generation, second generation, and third generation, you can see. And second generation, of course, we use altiplase. Third generation, we have very fibrin-specific, very effective tenecteplase. We all know those. And first generation, by the way, streptokinase, you have to understand, you should never talk about streptokinase now. And so this is a comparison of streptokinase and altiplase. And so this Gusto study and see very clearly. And so the altiplase is better than streptokinase. That's again very, very clearly evident. And so different thrombolytic agents, again comparison of streptokinase, altiplase, tenecteplase, and altiplase. You can see 90 minutes of patency after this each therapy. The best you can see with tenecteplase and altiplase, not streptokinase, is about 40 to 60% patency rate. Even now they say it's lesser than that. And comparison of altiplase and the tenecteplase, of course, now this study shows the ASCENT-2, tenecteplase was as effective as altiplase in reducing 30-day mortality. Now I know neurologists, they give this, they used to give altiplase, now they are giving tenecteplase. Apparently there are two studies, one is equal tenecteplase and altiplase, other one is actually tenecteplase superior. There is now lobbying actually for tenecteplase in stroke treatment. So I hope the cardiologists also doing the same thing. And the primary PCI. So primary PCI again can be defined as a reperfusion by means of coronary angioplasty or stenting for acute STEMI without prior administration of fibrinolytic therapy or any other antithrombotic agent. That is, remember, the primary PCI, the gold standard for STEMI treatment. And the latest ACCHA, that 2025, and ESC 2023 guideline recommend PCI, primary PCI, the initial approach to management of STEMI. That's very clearly mentioned, this thing, because early the better. And in patient with STEMI and estimated time for first medical contact to device activation, if it is less than 120 minutes, those patients with contraindication to fibrinolytic therapy transfer to PCI capable center for primary PCI. That is the recommended treatment. And this is primary PCI. You can see the first one. So you totally occluded, and then you do the opening, and then you get normal TIMI-3 flow. So it is the preferred reperfusion strategy for patients STEMI if performed in a timely manner. And again, the left side, you can see the LAD totally gone, and then we open the LAD and then have the normal perfusion. So thrombolysis versus primary PCI. This is the famous meta-analysis of 23 studies. It says the short-term clinical outcome in individual treated with primary PCI is very much better than the thrombolytic therapies. This study proved that, and primary PCI is the treatment of choice for STEMI. And then there's another strategy called pharmacoinvasive. This is actually coronary angiogram. You do with PCI of the affected artery and perform between 2 to 24 hours after successful fibrinolysis. And the timely thrombolysis and coronary angiography have a similar clinical outcome as primary PCI. Remember that you give thrombolysis therapy, nicely done, reperfuse, and then you do angiogram within 2 to 24 hours. And so see the lesion and do the PCI. And so this is as equal as benefits sometime with primary PCI alone. And so this is the study, early Mayo trial, published in 2017. And so this study concluded in low-risk STEMI patients presenting within less than 6 hours with expected PCI delay has to be again more than 60 minutes, and then only you decide on this. And pharmacoinvasive strategy using half-dose altiplase followed by early PCI provided better myocardial reperfusion than primary PCI and represent a practical alternative where timely PCI is not available. So therefore, you don't need to worry. And sometimes you give thrombotic therapy and transfer the patient early and make sure that and is nicely reperfused. So this study very clearly the benefits. And see pharmacoinvasive strategy, this particular patient gave streptokinase. Of course, when you do the angiogram, there is no opening here. Actually, it's not pharmacoinvasive, it's rescue PCI. I just want to highlight the effect of streptokinase in STEMI. And so, of course, patient we saved because of the PCI. So this is an inferior STEMI even after tenecteplase, but you can see this artery is open, TIMI3 flow. And so, but we did the PCI pharmacoinvasive later on. And so indication for rescue PCI, that's where fibrinolysis fail. That means ST segment resolution less than the 50% of the original at 60 to 90 minutes of therapy. And so patient with working diagnosis STEMI who present to non-PCI center should be immediately transferred to PCI capable center for timely treatment. And so then antithrombotic therapy briefly, and so determinant of antithrombotic therapy depending on various things, of course, patient characteristics and the clinical presentation, comorbid condition and all that, and then ultimately we have to select the type of antithrombotic treatments. What we have to do is balance the ischemic risk and the bleeding risk. And so this is again antiplatelet drug, dual antiplatelet therapy, clopidogrel versus ticagrelor. So based on these results of Plato and Triton TIMI 33 trial, DAPT including aspirin and potent P2I12 inhibitor, that is either ticagrelor or prasugrel is recommended for standard treatment for STEMI patients, non-STEMI patients. So this is the study, not the clopidogrel. And then another study, ISA-REACT trial, and also demonstrated clopidogrel characterized by less potent and variable platelet inhibition. And so this study, of course, significantly reduced composite death and MI and or stroke without any increase of bleeding. So this study showed prasugrel is better than ticagrelor for STEMI patients. And so again the selection, so PCI, non-STEMI situation, of course you could give the aspirin or clopidogrel or prasugrel. CABG if they are going aspirin and ticagrelor or clopidogrel. And so the thrombotic therapy patients, of course, if they are going for medical treatment, of course aspirin and clopidogrel. So that is the way it is recommended now. And early aspirin discontinuation. So people who have got all these therapies and even PCI, and you don't need to, in certain situation, if the bleeding risk is high, you don't need to complete the 1 year treatment. So this is a study to show that's TICO and TPAS trial that showed very clearly you can stop aspirin within 1 month and continue the ticagrelor, the balance. And so anticoagulant drug selection, again, other than the antiplatelet, you see the heparin. Heparin is given, and usually enoxaparin is preferred treatment compared to the unfractionated heparin in every situation. So that is you have to remember. And so then the complications. So we know that in acute coronary syndrome, we have all these complications, mainly the heart failure and cardiogenic shocks, left ventricular thrombus formation, ultimately they end up in strokes, the other arrhythmic condition, bradyotachyarrhythmias. And so ACC guidelines, of course, very, very clearly says, shock situation, the patient should be immediately get the patient and treat the patient with PCI and infarct-related artery. Don't attempt any other artery, only infarct-related artery. If you try to attempt other arteries, you do harm. And so a recommendation for ACS complications and various complications I have mentioned here, and especially mechanical complications. So they should be immediately angioed, and so check for revascularization possibility. And the bradyarrhythmias and tachyarrhythmias, again, immediately you should do the angio and treat accordingly, because you have to reperfuse, and while you are treating for this thing, the arrhythmia condition. And remember that there is another important thing in patient with, as Asanka is here, I have to mention mention this. In patient with post-MI, implantable cardioverter, that is ICD, implantation is recommended in selected patient with left ventricular ejection fraction is less than 40%. So at least after 40 days of post-MI. And so you have to decide, so revascularize after 40 days, still LV function is poor, I think one has to consider that. That's also important. And so then again, this low-dose rivaroxaban, never anticoagulant agents, and reduce ischemic event, but increasing bleeding risk. In patients with poor LV function, we used to, some recommended that NOAC, in addition to the dual antiplatelet therapies, some people give. But remember that ischemic complications are less, but there is a risk of bleeding there. You have to very carefully start this, the new NOAC on newer anticoagulant agent on top of a dual antiplatelet therapy because of the bleeding risk. This is a study to show that. And so follow-up patients, of course, early the discharge, of course, first 4 weeks, so you have to they do a clinical review, symptom assessment, and also check for medication. Sometimes a lot of people in our studies, we have done follow-up, a lot of people don't take medication, especially dual antiplatelet therapy. And adherence is very, very important. And sometimes you have to, this time you have to do echo and to assess the LV function. And follow-up, of course, supportive healthcare choices, smoking cessation, we all know the healthy diet, that is very important. Regular exercises, healthy weight, psychological management also important. And then drugs, antithrombotic therapy, usually dual therapy, dual antiplatelet therapy, lipid lowering treatment, beta blockers, MRA, SGL2 now is a new thing, so make sure that they are on, especially for diabetic patients with poor LV function. I'm not going to detail on that. Then AC inhibitors, or ARBs, or ANI. ANI is again now high on the list, so you have to start. And so then ACSJ 2025 guidelines strongly endorse, and long-term treatment, lifestyle measures, very important, that could reduce mortality in these patients. So therefore, cardiac rehabilitation is a key. And so in conclusion, so ACS is driven by two the critical forces. One is coronary thrombosis and time to reperfusion. That's very, very important to remember. Rapid recognition and early restoration of coronary blood flow remain the most important determinant of the survival. And the delays in presentation, system gaps, and the residual cardiovascular risk continue to impact the prognosis. So you have to address all those issues. And strengthening ACS system of care, the network, and from pre-hospital diagnosis to definitive treatment is essential to further reduce mortality. In Sri Lanka, in Western province, we have proven, and beyond any doubt, that we are lacking. We have gaps. So ACS is a race between the clot and the clock, and the survival depends on who wins. Thank you.
Should I have some Zoom questions? We have over 500 Zoom participants joining online here with us. So one virtual audience person has asked that I have seen many ECGs of young individuals with J-point elevations on inferior leads and V1, V2. But after investigation, they were not significant, maybe early repolarizations. How to differentiate those from STEMI?
Yeah, of course, very simple. And the most important for STEMI is the patient will tell you. You don't need to do anything. Patient will tell you. You have to listen to the patient. Most of the time, clinicians don't listen to the patients. And the patient will vividly describe the STEMI. And I have this thing I used to tell all the students and the PGs, and the palm sign. They will tell you pain, chest pain. They will never, if they say pain here, pain there, it's called finger sign. And so that is enough. And you don't need anything. And you don't need J point, R point, May point, you don't need. And of course, there are certain situations important, but the most important for STEMI is clinical diagnosis. And because sometimes patient, you say, no, sir, no, nothing, you go home, patient herself or himself doubt the doctor. They say, no, can't be, there's something wrong here. They come back and go to another doctor and see it's ST elevation here then. So you miss the bus. So therefore, the most important thing is not the J point, not the ST segment, is the clinical diagnosis. Once you make a clinical diagnosis, it's STEMI. So you have to start the treatment.
And we heard a lot of questions like I'm selecting selectively. So if there's a post-MI thrombus, what are the treatment strategies we have to start on, like triple therapy and the duration of the triple therapy, and then
Yeah.
degrading into the dual therapy.
Yeah, there are certain patients, of course, they develop thrombus. In that case, you have to do the triple therapy. And triple therapy, again, now see, starting on top of dual therapy and never anticoagulant agents, some say, but evidence is not that strong. And still the warfarin, so you have to give warfarin. And but some all depend. Some believe that this is the latest study I showed you, 2025, they published this year, 2026, and that shows if you add never anticoagulant agents, sometimes there is a bleeding risk. Of course, you minimize you have a benefit, but there is a risk of bleeding. And so still the warfarin, you give warfarin, and so in that case, so you have to give, depending on the, you have to strike a balance. It's a trade-off between ischemic complication and bleeding complication here. Suppose if the patient is having high risk of bleeding complication, then might as well stop the aspirin and so early, maybe 1 week, maybe 2 weeks, maybe 3 weeks. Usually 1 month you stop and continue with the other P2Y12 and the warfarin, and then reassess every month and see the thrombus and whether it's dissolving or not. Usually keep the INR between 1.5, 2.5. Usually these people improve and very well, and then you slowly stop it and and see, monitor. You have to monitor them.
Thank you, Gota. Very interesting and excellent lecture. Thank you very much.
Thank you.